Thank you for joining us today. We'll get started in just a minute. We'll give people a little bit of time to get into the Zoom room. Thank you for joining us today. I'm Judy Thomas, CEO of the Coalition for Compassionate Care of California. And we are excited to share our third webinar in our three-part series about our experience with making community-based palliative care a more normal and routine part of healthcare through the development and evaluation of consensus standards for community-based palliative care. Just a few housekeeping items as we get started here. First, the webinar is being recorded, and you will receive a link to the recording in the next few days with both the slides and the link. So please look for that email. Second, we will be using the chat box for questions. So please feel free to post questions in the chat throughout the webinar, and we will also pause to answer questions during the webinar. For those who aren't familiar with the Coalition, we've been around since 1998, and we are a nonprofit dedicated to creating a future where people can live their best lives possible during serious illness. And we do that by making conversations about serious illness a part of everyday life and palliative care a part of everyday healthcare wherever people receive care. I'd like to take a moment and to thank our sponsors. First and foremost, I would like to thank the California Healthcare Foundation, whose generous financial support funded the demonstration project that tested and evaluated the impact of the consensus standards and is the focus of our webinar series today. I'd also like to thank the John A. Hartford Foundation and Atlantic Philanthropies, whose financial support through the Practice Change Leaders program made development of the consensus standards possible. And lastly, I'd like to thank our national partners that sponsored this webinar series, including NHPCO, CTAC, and HCCI. Now I'm going to hand, thank you. I'd like to just quickly introduce our webinar speakers. As you know, we have Brian Castle, who is a PhD researcher in palliative care and associate professor at Virginia Commonwealth University, and Kathleen Kerr, who's a healthcare consultant in palliative care, and myself. Now I'm going to pass it over to Kathleen. Thank you.
Hi, everybody, and thanks, Judy. So for today's session, we're going to start by briefly reviewing the standards for community-based palliative care, in case any of you didn't catch the first and second webinars. And then we're going to move into exploring some topics about our experience developing and implementing these standards, really with an eye to helping those of you who might be interested in developing standards for your region or your state or your organization to learn from what we gleaned from our experience. We will be pausing for discussion throughout, and we'll also have some time at the end. And just as a reminder, the webinar is being recorded, and a link to the recording as well as the presentation slides will be sent to you. So what we're going to be describing our experience with is two sets of standards that have been in place for community-based palliative care in California. The first, the consensus standards for community-based palliative care in California were developed in 2016. There was a coalition that was assembled by the Coalition for Compassionate Care of California that included payers and providers and policy experts and researchers and so on, a big group, a big diverse group. The standards were released in March of 2017, and they're really intended to define minimums. So recommendations and requirements that would be acceptable to any payer or provider. And they're very specifically intended to inform contracting for home-based palliative care. These standards were developed at about the same time and released close to the time that there were a companion set of standards for Medi-Cal enrollees who were seriously ill, who were eligible for palliative care. The state of California released a mandate and then some standards that went along with it. And those standards for Medi-Cal enrollees in particular are well aligned with the consensus standards that were developed by the coalition. So in terms of what's in the standards, they address several key areas that folks would need to think about if they're looking to increase access to and standardize home-based, community-based palliative care. They speak to eligibility, the patient population that would be served, the specific services that you want to make sure those folks get, and also staffing and providers. Who are the individuals and organizations that should be delivering this care? Now, in addition to those three areas, which are both all specified in both the consensus standards and the Medi-Cal standards, the consensus standards also address payment model as well as measurement and reporting requirements. Those issues are not addressed in the Medi-Cal standards. And it's important to note here that the standards are to be used as a supplement to, not instead of, the clinical guidelines and expert consensus and literature that guides our philosophy of what does good palliative care look like. So you'll see in the figure here, there's the National Consensus Project, Clinical Practice Guidelines for Quality Palliative Care, that holds guidelines and recommendations for what does it mean to deliver quality care. Those recommendations inform the delivery of palliative care across settings, including community or home-based palliative care, which is specifically addressed in the standards. The standards take those recommendations that were made in the expert guidelines, and the goal is to really operationalize them, to support delivery, to set expectations for contracting, and to focus on the needs and preferences and issues that both providers and payers face, whereas the NCP guidelines are probably more directed towards just a provider audience. So standards plus guidelines, not standards instead of guidelines. Once the standards were developed with the support of the California Healthcare Foundation, the coalition led an effort demonstration project, which ran from 2018 to 2021, which had the goal of implementing the standards with a group of payers and providers. The goal was to evaluate outcomes and to look for variation in care delivery. How do the standards perform? And really to kind of get at this question of, do the standards make it easier for payers and providers to develop and implement contracts that increase access to quality, sustainable palliative care services? So the participants were assembled in 2018. There were multiple payers and multiple providers delivering home-based palliative care in two regions of California, Sacramento and Los Angeles. The contract requirements for that define the relationships between these payers and the providers, they all met or exceeded the requirements that were put forward in the consensus standards or the SB 1004 requirements, depending upon the line of business. And we did have representation from Medicare Advantage, commercial, as well as Medicaid lines of business. Many, but not all of the providers were contracted with multiple participating payers. We ran a claims analysis to look at financial and utilization outcomes that used data from calendar year 2019 through March of 2020. And we did qualitative data collection and group activities all the way through to December of 2021. The project was led by the Coalition for Compassionate Care of California, and it was funded by CHCF. And it was supported by an evaluation team and an advisory group. I would say that if you want to learn more about what went into the demonstration project, the activities, details about the findings, please do go check out the first two webinars in the series. The first one really focuses on variation and impact. The second one is very focused on the claims analysis and fiscal outcomes and issues related to sustainability. But briefly, some of the key findings that came out of the demonstration was that the standards were largely successful in promoting delivery of team-based care that aligned with the NCP guidelines and other descriptions of best practices. The evaluation did reveal variation in how the standards were enhanced and implemented, and that variation, a good bit of it was expected since the standards define a minimum and we expected people to build on them. And there was a mix of manageable and problematic variation. And when you step back and looked at, well, where was the most variation and which of that was causing trouble, the biggest place where we saw it was in the measurement and reporting realm. The preliminary assessment of financial outcomes showed positive results. It looks like the services were having a good impact on total cost of care as from the payer perspective. And there was variation in the degree of impact across insurance types and also on the plans, each of whom had different implementation choices for the standards. And finally, the variation in financial outcomes really appeared to be linked to those implementation choices. So with that brief introduction to the standards and what we did in the demonstration project, I'll hand it back to Judy to talk about lessons related to developing standards.
Great, thank you, Kathleen. So just a quick reminder that standards are very important and the need for standards are outside of California as well. It's not just California, but we need them broadly because without standardization, we have a chaotic environment as to what constitutes community-based palliative care, and that creates a barrier to scale and sustainability. It also opens up the delivery of this care to being provided in a way that is ineffective, inefficient, of low quality, or even fraudulent or misleading behavior. Because when it's unclear what constitutes palliative care or community-based palliative care, it's easy to have slick marketing that's not backed up by real services. We also don't want to simply replace hospice with palliative care. We want to expand the patient population that receives the benefits from palliative care. And we want to make sure that providers of community-based palliative care have the resources they need to do this right. As stated in this article that appeared in JAGS in response to a publication related to the provision of community-based palliative care, they point out that standards are critical to patients, families, referring clinicians, and payers, so that we have the predictable and reliable delivery of community-based palliative care. And that is essential to sustaining and scaling these kinds of services. Next slide. So how do you go about creating standards? Well, first you want to assemble a committee that reflects the perspective of key stakeholders. This definitely needs to include payers and providers, most likely multiple payers and multiple providers, since there's many types and flavors of payers and providers, and you really want to hear all perspectives. We also found it helpful to include academics, foundation staff, policymakers, associations that represent the key stakeholders, and diversity when it came to profession and discipline. We also recommend including referring providers, those folks who are already caring for these patients who would benefit from community-based palliative care, as well as the patient and caregiver voice and perspective. That is something that we relied on in creating the California standards. And if we were going to do it again, we would include these groups. Having a neutral third party serve as the convener helps with bringing people together and around the table. And this could be a foundation, a state agency, a coalition like we have in California. But having that neutral convener makes it clear that this is about creating a win-win-win-win situation for everyone that benefits patients, providers, payers, and the public. Next slide. So we found it helpful to achieving consensus to focus on defining a floor, a minimum standard, something that everyone could agree on and get behind. You could enhance that floor by specifying aspects of the minimum standards that could be enhanced, making it clear where and how you expect that variation to show up. Also, it's easier to achieve consensus on the what aspects of community-based palliative care, not the how aspects, which will vary much more between organizations as you start to get down into more nitty-gritty details of like workflow and processes. But don't be shy about using existing standards and leveraging existing literature in crafting your standards. And at the end of the day, the proof is in the pudding. If the standards you've created, they need to be acceptable to payers and providers alike, or else they won't be used. Next slide. So Kathleen showed you this chart that we have here, which does emphasize the value of using foundational pieces of this. We have several well-vetted national clinical guidelines to build off of, including the National Consensus Project, which provides clinical guidelines across 8 domains of palliative care, ASCO clinical guidelines regarding palliative care involvement in cancer care, discipline-specific training and certification for professionals that provide palliative care, accreditation standards for program level accreditation, and quality measures that evaluate the processes of care. And all of this can be used to help craft a set of standards aimed at operationalizing the delivery of community-based palliative care in the home. Next slide. When developing these standards, keep in mind what's going on in the larger palliative care context in your target community. For example, does your state already have standards related to community-based palliative care or even palliative care more generally? Is there pending legislation or regulation around palliative care? Is there any work already underway? You want to be aware of that and try to leverage and incorporate and work in collaboration with it. Also, are there any licensing issues that might facilitate or hinder providers from providing palliative care in the home setting? Look also at the federal programs. We've had a lot of innovation in the last few years, and how are those programs being implemented in your state? Are there lessons learned or to build off there? Take into consideration your unique healthcare market. Do payers in your area already cover community-based palliative care? If so, how do they define the program, and what are the key components of the service or benefit? Do you have providers that are already providing community-based palliative care? If so, what is the structure of their service and how do they sustain it? Keep in mind that if payers or providers are already offering the service, they will likely want the standards to be consistent with what they are already doing. And that's likely to be a good thing. Sometimes it might not be, but you want to build off of that and work with what is already happening to expand on that and to drive it in the right direction. Also, what's the penetration of managed care, accountable care, or value-based care in your market? That will impact the dynamic between payers and providers. Is your region rural or metropolitan, or does it include both? And again, this may impact certain aspects of the standards. For example, rural providers may not have access to as rich a continuum of skilled clinicians as is available in more densely populated areas. So that might impact some of the expectations about how the service is staffed. Next slide. So how do you go about the process of creating standards? First, you want to have a staff person, someone who is assigned as part of their day job to do this, to do the project management aspects of this process. In California, we first tried to do this on a voluntary basis, but we were spinning our wheels until we had a staff person. Also, it's helpful to have an influential person to serve as chair of the effort, and that can motivate people to participate. The first thing that we did was create a charter, which sounds much more complicated than it actually really was. Really what you want to do is write a description of the purpose of this effort and what is the level of commitment that you're asking for from the stakeholders that you're going to invite to be a part of your committee. And you need to take time to plan your meetings, to have agendas. And there's a lot of work that needs to happen between the meetings because you want to prepare content and discussion items that are going to move the dialogue along. And after you have a meeting, then you need to process that and think about it. And it's usually easier for people to respond to a straw proposal than to kind of blue sky brainstorming. And one thing to keep in mind is what we found, this was before the teleconference days, but when we met by phone, we had great discussions, but for some reason, it seemed like people weren't tracking the conversation. When we get together in person, we alternated phone meetings with in-person meetings. When we got together in person, we were having those conversations and some of that foundational communication from scratch. So that really seeing each other face-to-face is very helpful to keep it moving along. And also there's some brainstorming that's kind of hard to do by Zoom, even though we're so used to it. So I really recommend thinking about how you can have as many in-person meetings as possible. Next slide. So now we have a few minutes if there's any questions.
Hey, Judy. Not at this time, except there was a question about further dissemination. Will you be presenting this information and the data on value impact to members of the National Association of Medicaid Directors and/or AHIP? So how do you feel about additional dissemination?
Yeah, we love those ideas. That's great. We definitely want to get word out about this. Appreciate those suggestions. We will be doing a presentation, Kathleen and Brian, at NHPCO, at the California Association of Health Plans. And Kathleen and Brian are working on a number of articles that will appear in peer-reviewed journal publications, and we'll be putting a lot of information on the coalition's website.
Great. Thanks, Judy.
So now I'm going to hand it over to you, Kathy.
All right, thanks. So now that we've thought about developing standards, I want to spend some time thinking about lessons related to implementing the standards. The standards, no matter how good they are, have to perform in the field, and we learned a lot about how to support those efforts. So one of the big lessons that came out of the evaluation and sort of the whole demonstration project as we watched folks go about delivering care that was based on the standards is that standards plus good implementation choices result in reduced problematic variation and reduced negative outcomes. So it's really those two things, the standards and how they're implemented, that drive your outcomes. And it's really important to be aware of that if you develop standards and you're looking to have them utilized in a way that gets everybody the results that they're looking for. So it's good to pick the standards as a starting point, even if you spent months or maybe even years developing them. And you can, one of the reasons for this is that the standards, in order to be adequately flexible to accommodate regional variation or variation in different stakeholders, you can't say a lot precisely about how. They make recommendations about what to do in ways that allow for enhancements because they're minimums. So by design, you have quite a few decisions to make about the enhancements that you might adopt. So what would you add to the minimums? And then choices about how, in what ways will you implement the standards? And there's examples of this across all of the areas that the California standards address. So in terms of eligibility, a particular plan that's administering the standards, that's building contracts that are based on the standards, they'll have decisions to make about, would you add specific diseases to the minimum population to be served? Would you relax the disease-specific eligibility criteria to open up access? And then even if you do that, even if you don't do that, you have to make choices about how. You have to make implementation choices. So how will you identify potentially eligible members? What strategies will you use? What method will you use for verifying eligibility? What strategies will you use for promoting referrals? And what strategies will you use for engaging members who've been found to be eligible for the service? You have to make all of those how choices, even if you don't make any of the enhancement choices. And this is true across all areas of the standards. The services, will you add them in terms of choices about implementation? Will you have requirements for the frequency and mode of contact for specific team members, detail that's not included in the standards, or will you leave that up to your contracted providers? Will you require use of specific screening tools and assessment tools to ensure best practices in standardization, detail that is not gotten into in the standards, or do you want to leave that up to your providers? And we see the same thing with staffing, with payment model, and with measurement and reporting as well. Next slide, please. And next slide after that. So given the importance of the choices that you make about enhancing or implementing the standards, it's really important to have implementation supports that go along with the release of the standards. And a little bit of this work was done through the demonstration project. We held in-person and virtual meetings. All of the 4 plans that participated got together and agreed on a universal referral form that could be used to refer patients to any of their programs in Los Angeles. That was so well received by the providers who were making referrals. There was a qualitative and a quantitative evaluation of the standards in practice, and the findings were funneled back to the participants. And there was also a cross-provider review of the patient and family experience assessments. What tools were you using and what kind of response rate were you getting? So some of this happened in the demonstration project, but it wasn't a huge focus. The big focus was really on the evaluation. And part of the reason why we felt comfortable doing that is that at the same time that the demonstration project was occurring, there were quite a few efforts related to providing implementation support related to the Medi-Cal standards. And you'll remember that we were using both of those standards when in the demonstration project. And I want to walk through some of the specifics here because it's the type of thing that any region or state or even health system or health plan could do to promote optimal adoption of any standards that they develop. So we're going to talk a little bit about a pilot test that was done and how useful that was, monitoring activities, promoting peer learning, technical assistance supports, and developing resources. And the one thing I'll add is that for all of these, sort of a universal goal across everything is highlighting how palliative care aligns with other state or plan or system or whatever organizational programs to support integration. The last thing we want is for community-based palliative care to be siloed, to be a bolt-on to everything else that's happening, and really thinking about how this program operates in the context of other priorities and other programs is really central to success. Next slide, please. So first of all, pilot test. If you develop some standards and you want to support adoption of them, a pilot test can be really useful. One of these occurred with the Medi-Cal standards. It was from an early adopter health plan. The pilot occurred well before the final standards from Medi-Cal palliative care were released by the state, and also before the final standard, the final California consensus standards were released. And this was a small study. It took place over 6 months. There was a qualitative component, which did a really nice job of assessing the experiences of the plan, of the contracted providers, as well as the members who were served. It also included an evaluation of fiscal outcomes. And the results of this, it was really positive across the board. And it also pointed to some things that might be adjusted to enhance the feasibility and sustainability and acceptability across all parties. But having this small pilot done really increased confidence across some plans that were being asked to implement something that they had no experience with. It showed that at least in the small sample that was reviewed in the pilot, that the fiscal outcomes were just fine. You weren't going to lose your shirt on this. So really, really relatively low investment and effort for a lot of benefit that helped folks who came along after early adopters. Oh, and there's a link at the bottom of the slide here. There's a brief write-up of the pilot that you're free to access. Another implementation support, which again, just about anybody could implement, is monitoring performance through annual surveys. Looking at acceptability and feasibility and promising practices and all those things early on is really useful. But looking at it over time as people gain more experience, that is super useful. So in California, with the support of the California Healthcare Foundation and the Coalition, we administered separate but very similar surveys to both plans and providers, asking about everything from how many referrals are you seeing, what are the enrollments like. We were able to document a range of plan approaches to payment model, which was not specified or narrowed at all. That was left entirely open in the Medi-Cal requirements. We asked about any revisions that were made to the eligibility criteria. How did you enhance those minimum requirements? How did you enhance the required services? We were able to gather information about the characteristics of the providers that were delivering palliative care through these programs. And also we got information, we sought information, and folks were very generous in sharing about their challenges that they were experiencing, about things that were working well for them, which became focus areas for technical assistance efforts and also developing resources. And I would just say again that people were so generous in sharing their data and their experiences and their recommendations and so on. And I have no reason to believe that anybody who uses standards that you develop would be less generous in sharing their information. One thing that I would want to point out here is that as useful as these surveys have been, they are not effortless to administer. And if you consider the figure here, if you think about effort along the x-axis continuum, and it can go from send a few requests and hope that people respond, and on the other side of the continuum, stalking, so kind of dangerous or alarming behavior, we ran pretty close to stocking. We provided many requests for people to fill this out. We got in touch with them individually. And it's not because we sensed any reluctance to share, it's just that people were super busy. And there's response fatigue, I think, overall. But we've been very successful. Like, for example, in last year's survey, this year's survey is in the field right now, we had responses from 19 of the 23 health plans that were involved in delivering palliative care to Medicaid enrollees, and we heard from 31 provider organizations. So effort required, it pays off. Don't be shy about elevating the importance of your invitation to share information through surveys. The next implementation support is really promoting peer-to-peer learning, which is by far the most favored that we heard from folks. They want to hear from each other. And one of the ways that you can do that is through convenings. By having an annual meeting that included plans and providers, we created a forum for reporting out the results of the survey, sharing back the collective experiences of plans and providers as a way of saying thank you to everybody who shared their information. Also, just a lot of learnings coming from that. The meetings were used as a chance to engage in peer-to-peer learning. So through discussion, following sessions, and even through having sessions that were specifically designed to showcase innovations in the delivery of standard adherent palliative care that were developed by both plans and providers. And these meetings also really created a booster shot of visibility for palliative care. The plans are involved in administering a ton of programs, and this is true for Medi-Cal and other lines of business as well. So having these points in time when everyone would come together and reflect on what happened in the prior year and what they want to have happen in the next year, super useful and something that you might consider replicating. It's also, I want to point out that in most of the programs most of the implementation supports that were developed by the coalition and sponsored by the foundation were aimed at both plans and providers, and they often occurred concurrently. But it can also be really helpful to have plan-specific resources and plan-specific meetings, just because there's a particular perspective and a type of learning and an appreciation of the breadth of both regulations and requirements and plan and other programs that plans can talk to each other about, where maybe it's less comfortable to do so if the providers are in the room as well. So for example, in California, the coalition has sponsored the creation in fall of 2021 of a Medi-Cal managed care plan, palliative care learning community. And we run these, there's events every month. They alternate between sort of open forums where brief meetings where folks can come in with an actual question, something that's on their mind that they're struggling with and they want to get some feedback from their peers. And then there's kind of more focused and practical sessions where we look at a particular program, alignment of palliative care with some broader Medicaid program, such as population health management, review tools and processes, things that will help to make the palliative care program run better or better integrate it with the other programs that the plan is administering. So plan-specific offerings can be super helpful. Another recommendation, another type of implementation support is to offer individual and/or group technical assistance. We started doing this immediately before the Medi-Cal standards were released and shortly before the demonstration project was launched. We offered these, originally we thought, oh, we'll have some for the plans and some for the providers, but plans and providers signed up for all of them, and it wound up being super useful, having folks together in the room, in particular at this time when we were looking to launch the standards. So the ones that we offered in California, there were 5 topics. We held a couple different sessions in Southern California and in Northern California to minimize travel time for folks. They were very practical, a lot of focus on the specifics of how do you interpret the standards and link them with implementation choices. And folks just really felt, they really appreciated the opportunity to all be together, both with peer providers and peer plans. And then also even some regions, the plan came with the folks who they were contracting with to deliver palliative care, so they could have a working session across organizations to figure out how to make this happen. And folks reported that it really increased their confidence and that they also liked hearing from each other. And again, this is the type of thing that you could do on a state or regional or health system level to support implementation of your standards. Another useful strategy has been to take materials that were developed through technical assistance offerings or through the convenings, and to curate and collate those and make them available via the websites. So people can download them and go back and review them at their leisure. All of the information that was developed for the technical assistance workshops, for example, was then put onto a dedicated website, and the information was free to all, well organized. There's you put the URL there. You're welcome to go visit it and download any of those materials. And they could certainly be adopted or adapted to meet your needs. So making information available for folks who prefer to learn independently, or where their need for it becomes apparent to them after the time that it was initially presented, either through an in-person or virtual meeting, really useful way to support implementation and sharing best practices and promising practices. Speaking of which, one of the things that you ought to make available widely and to really try to disseminate is promising practices. And if you have new standards, it's unlikely that you're going to be able to go to the literature to look up best practices related to implementation issues. Those are best documented and discovered by looking to the experiences of the people who are using the standards that you've created. So for example, working from the implementation, from the technical assistance workshops, as well as the annual convenings, we were able to, and also the experience of the folks in the demonstration project, we were able to assemble some brief write-ups, really practical, that get at some of the main implementation choices that folks have to make: identifying eligible patients, engaging patients, referral processes. There's 4 of these, I think, in total. They address challenges and barriers, brief descriptions of strategies, including rationale and considerations in case you need to modify it to meet your particular situation, a brief bullet points of key lessons learned. These are Medi-Cal specific, so Medicaid specific, but the content is quite generalizable. And having something like this that folks can go and look up themselves, or that you can use if you're working through a one-on-one technical assistance to refresh people's memories about what's been discovered in the past. So really what we're advocating for is creating a flexible ecosystem of supports that accommodates different learner preferences and different roles in the standards. So you have curated resources, and those really are attractive to folks who prefer to learn independently, but they also become resources for technical assistance and the learning community. The learning communities can promote peer-to-peer learning, and as that learning happens, you can document what was shared and plug that information into one of the forums that you use for curating resources. And then technical assistance can be done with groups. It can also be done one-on-one. There's a program that's happening right now where we're offering intensive one-on-one assistance to health plans that are looking to do anything from a structured needs assessment to redesigning and relaunching their palliative care services in the setting of a big redesign for Medi-Cal in general. And materials that are developed through technical assistance can inform the learning community work, and it can also be uploaded as a curated resource. So all of these things can support each other, and hopefully by making information available through a variety of formats, you can appeal to a variety of different learner styles. Okay, that was a lot, but it's really important. So I'll pause here. And Brian, are there any questions about implementing standards?
Yes, there was a couple of questions. One of the questions from Dr. Dan Hofer came in just as the earlier section was ending up. And that asked the kind of classic question of, when you standardize practice or scale it up, how do you ensure that you're not enforcing or reinforcing bad practices for bad outcomes? So in your view, or in Judy's view, what is it about the standards and the implementation that is evidence that bad outcomes were not produced? And what is it that you would recommend that other people do to avoid bad outcomes?
Yeah, thank you, Dan. It's a great question. And Brian, I think you'll get at some of this in your section, but I think that part of the implementation supports that you can have in place is continuous assessment of what's happening with your processes and your outcomes. And if you pick that up just through routine measurement, that can be fed back to the plans and to the providers, and hopefully you'll be able to tease out poor implementation choices that seem to be linked to outcomes that aren't what you hoped for.
Great. Thank you. And yeah, I'll address that a little bit too in the evaluation section as well. A couple questions from Zilvanda Sutton about this gray area where folks, either payers or providers, are free to make their own choices about how to achieve something, how to implement, or to perhaps go beyond the minimum floor set forth in the standards. What would you say is recommended guidance about those good kind of choices versus maybe not so good choices? Do you have any reflections on that?
Yeah, I think a lot of the pros and cons and considerations for implementation choices, we tried to capture those, for example, in the promising practice write-ups. So you could go this route, you could go that route, and these are the things to consider. I think that as more groups in more regions have more experience with implementing standards, we'll be able to really differentiate good choices versus poorer choices, and to the extent that they really impact quality and patient, clinical quality, patient experience, patient-centeredness, ensuring equitable access, and so on, with more confidence, those could be folded into the standards themselves. But for right now, where there may not be rigorous or broad evidence about what's a good implementation choice versus a poorer one, I think the best that we can do is offer up other people's experiences, which is one reason why, and also to monitor continuously, and that really gets to this idea of curating and making available all of the information that you can about people's experiences implementing standards.
Thank you. We have a question from Dr. Bob Moore about going beyond evidence for palliative care working, let's say, with particular populations or particular disease groups. Great to have that freedom, but kind of a comment that you can't necessarily guarantee or extrapolate from evidence on cancer that it's also going to work for renal disease, let's say, and those are my words, not his. But any thoughts on that about when people go beyond the minimum or go beyond the 4 diseases that are specified in the Medi-Cal guidelines, how carefully should they evaluate outcomes?
Yeah, Brian, I think that and first of all, thank you, Dr. Moore, and absolutely right. There was some great information, Brian, that you were able to pull out by looking at the distribution of the disease profiles of the folks who participated in the demonstration project, and looking at differences in length of service and the concentration of those across plans, depending as dictated by their implementation choices. And so it isn't all the same, but it's also in some ways the same, more the same than maybe you would have expected. And so I think it's a great point of, if you want to expand access, monitor your outcomes and look at how it plays out, as you add diseases, and you can do that in a way that's not in a feasible way to sort of track things as you go. I think some plans were reluctant to sort of specify additional diseases. Others were quite upfront with it, but all sort of had a practice of having a catch-all category where if they heard about, if a patient was referred or they saw a patient or a member where it seemed like they would benefit, even if the disease wasn't specifically referenced in the standards, they felt it was their practice to accept them in. But this is also something that over time, as people make these services available to a wider population, we'll learn more. about how the standards function across more disease groups. And then that information can be fed into the standards. And maybe instead of only specifying 4 conditions, it can be grown out to specify 9 or 10 or 11 or, even more.
Right. So what I hear you saying is don't hesitate to continue innovating, but take Dr. Moore's suggestion that also puts a onus on us to continue evaluating as well.
Yeah.
Well, let's stop there with the questions now. I'll do a brief section on the evaluation of standards and of standardized services, and then we'll have another round of Q&A after that. So as you might recall from the previous webinars, if you were able to join those, and if not, we again hope that you're able to access those which are available freely on the website. There's 3 evaluation aspects with the demonstration project that was done from 2018 forward for the California standards, consensus standards for community-based palliative care, from payer perspective, from provider perspective, and then from kind of a third party or external perspective as well. So providers typically, though not uniformly, evaluated patient and family experience of those who were receiving palliative care services in the home. And they self-assessed some process and outcome measures, as well as some business aspects of providing care vis-a-vis their contracts with each payer. The payer evaluation efforts that are done internally and independently start with the foundation of compliance, making sure that providers are compliant with eligibility guidelines and the services that are expected and contracted for, but also looking at enrollment duration. Are we seeing what we expected as a payer when we started paying separately for home-based palliative care, or people receiving it for 2 weeks or 2 months or 2 years? And what was our goal in providing this in relation to other forms and modalities of care, such as hospice? Another thing is that they would self-assess their fiscal inputs and outputs, or in other words, what they're paying for home-based palliative care to provider groups, and what impact is had either in terms of clinical outcomes, patient experience, or fiscal outputs as well. One key thing about the demonstration project was that the foundation and the coalition was very serious about evaluating process and standards and outcomes. And some of that work was done sort of within the payers and providers, which was facilitated via convened meetings, where folks came together and reviewed and provided feedback about each of those 5 domains that are in the California standards. Other aspects were done with the help of outside folks, such as Kathleen and myself. So third-party interviews with payers and providers that were one-on-one to try to get a little bit, outside of a big open room where everyone's going to see you. What did you really feel about the standards and about standardized services and about the outcomes? And then the analysis that we did at VCU of enrollment and claims data that we acquired and pulled from 3 of the payers and put that together. So that mixture of evaluation efforts might be something that folks would consider elsewhere in terms of ensuring that delivery has fidelity with the standards and ensuring that outcomes are as what one would expect and not what one feared. One of the points we'd like to make is that you can have consensus on written standards that predates their implementation and their use. But it's important then when practice has taken place, when services are contracted, when services are being delivered, to continually assess the acceptability to the providers and to the payers and to other stakeholders of the arrangements and of the situation. And that's a very subjective thing. That's not necessarily saying symptom scores reached a certain level or patient experience scores reached a certain quantitative level. The acceptability of standards and standardized services is much more subjective. One example of this is in the area of cost outcomes. So for some payers, a higher cost of care from home-based palliative care in their total cost of care of those beneficiaries might be acceptable. It might be something where they see such great outcomes at the patient level or in the community that they're willing to say, well, why not we pay for outcomes? These are great outcomes. That's fine. Other plans may expect to see a break even or even a positive return on investment from the payments for home-based palliative care. So understanding also that is part of the subjectivity of expectations, and that might differ from party to party. Another way of evaluating acceptability of standards and standardized services is through behavior. Do payers and providers continue to participate in these kinds of contracts and services, or do they drop out? So that's one thing that you would want to track over time. We'll say a little bit more about the challenges in the third-party fiscal evaluation that were conducted. Our goal was to have all 4 payers who signed on to the memorandum of understanding that they would extract and transmit data to the evaluation team at VCU in order to have a shared view of volumes, duration of enrollment, cost of care, and the impact on the cost of care. In reality, what happened was that 1 out of 4 of those payers did not come to an agreement on data sharing with VCU. In order to evaluate outcomes, most of what has been done in the field in palliative care compares decedents with and without palliative care. So we asked payers if they were acquiring death dates for their beneficiaries. 2 did and 1 did not. So that made that difficult to use as a metric or an approach to evaluate fiscal outcomes. As a backup to that, another thing that's done in the field is that palliative care recipients are compared to those who were eligible for or actually referred for services, but who did not receive services. And again, only 2 out of the 3 that provided data said yes, they had that. So that made makes it challenging to identify the comparison group for palliative care recipients who might not look like most of beneficiaries in a payer's line of business. We had some technical problems around the way we asked for the data and how we got it. Did not make it easy to compute the number of hospitalizations and bed days, which might be somewhat separate as measures of palliative care impact from total cost of care. And with different payers, there's challenges with capturing costs of care in instances where there is delegation or capitation of payments. One thing that was a challenge for our field, and was certainly a challenge in this demonstration project, was the area of getting the patient and the family perspective. So there's a lot of variation across providers in how they do that. And during the course of the project, the RAND Corporation developed, led by Rebecca Price, developed a great new tool for home-based services for people who are seriously ill. You see the URL there, see a picture of that. We highly recommend that people take a look at this and consider this as a way to have a more standardized measure of patient experience for home-based programs. It's also a way that you can use enrollment data to try to get at some patient and family experiences by looking at the proportion of enrollees who disenroll due to patient choice, as opposed to things like death or going into hospice and whatnot. We certainly in the field would continue to recommend that people place a premium on evaluating patient and family outcomes of palliative care, since they are at the center of the work that we do. And a lot of the other measurement that has to be done should be secondary to that. That's harder to do than it is to say. Takes a great deal of effort to evaluate patient and family outcomes, and there's issues also with HIPAA and confidentiality as well. So our recommendations about evaluation are that folks continue to evaluate. We certainly need a lot more evidence in the field about successful standardization of services, successful scaling, sustainability of home-based medical services, and even specifically about case rate contracting or value-based payments. Whether you have a very formal evaluation process or one that's a little bit more informal and relaxed, a feedback loop between the payers and providers is something that the convening entity can help to provide. We'd also encourage folks as the California folks have done, put these things out there on websites, the implementation tools, the supports, the standards themselves, and the findings from their evaluation. So take a minute here to go over the 9 key recommendations based on our experience with the demonstration project and the Medi-Cal work as well. And those are, in terms of standard development, that you seek and incorporate input from a diverse group of stakeholders, that you use standards to define a floor plus optional enhancements where people can go beyond the minimum, and that you achieve a balance between high specificity of what is standardized with the need to accommodate the variation that has to exist between entities and regions and whatnot. 3 recommendations regarding effortful implementation. Kathleen mentioned that it was not effortless to have a high response rate to the surveys, and I think a good word for the entire body of work that the coalition and the foundation have done to support implementation around Medi-Cal palliative care and home-based palliative care is effortful implementation, to provide a range of implementation supports for payers and providers, to collect and share information about promising practices, again, that feedback loop, and to create opportunities for peer-to-peer learning that people place a lot of trust in. And in terms of evaluation, we recommend that you evaluate the acceptability of standards and standardized practices, feasibility of providing services, impact of services, and sustainability over time. We urge people to consider using and promoting others to use a single patient experience survey so that results of patient experiences might be more comparable and uniform across providers and payers. And just as a principle, we hope that folks make their standards and their findings from implementation easily accessible to all. So that brings us to our final question and discussion period. We have just a few minutes left.
Hey, Brian, there's one here that was put in the chat, a question about disease-specific measures. Are there any that have been developed for different specific populations receiving home-based palliative care? Or they tend to be a little more general, like length of service and hospice referrals and that sort of thing?
Researchers certainly have a ton of disease-specific measures for heart failure, for cancer, and whatnot. For real-world folks, there tends to be a broader use of universal measures. Not that you'd expect the same result for different disease groups, but at least the measures of interest, like duration, like reduction in symptom burden, patient and family experience, some kind of predictable and controlled total cost of care, that those things are more universal for palliative care across diseases.
Great, thank you. Yeah, it also brings up the, do you want disease-specific measures? Or if it's offered to a population, is it useful to have measures that are appropriate for anybody who's enrolled? It's an interesting conversation.
You can certainly start at the broad level and then kind of drill down and say to your cancer patients and families, you know, what's most important to you? What's most important to you about palliative care provision? Some people, some diseases might say, keeping me out of the hospital. And other people might say, keeping me out of pain. And those are 2 different goals. And that would indicate that for one disease group, your primary patient reported outcome would be one thing, and for another group, it would be something else.
Yeah, I really love that because it links back to implementation choices and everything from which disciplines see different patients at different frequencies based upon preferences that have to do with characteristics of a specific population. We'll get there one day. Hey, I'm seeing it's 11:59, so we should probably go through the last couple slides. So first of all, I just wanted to thank all of the plans and providers that participated in the demonstration project, who shared their data and their wisdom and their perceptions and their recommendations, and also been doing amazing work helping seriously ill Californians. And just a reminder that the coalition is having its 2022 annual summit, Emerging Stronger, Creating the New Normal, will take place in San Francisco in early May, and there's a link there to the registration. And there's a coalition webinar series, a few events coming up across the course of the next few months. There's a website where you can go to learn more about these. They tend to be quite practical, very well attended, and we hope useful to you as you go about offering these services to seriously ill folks. And with that, please do visit the coalition website. Thank you so much for joining us today, and hopefully in prior webinars as well. And we'll get out a link to the recording as well as the presentation materials, and maybe one or two other things via email in the next few days. Judy, Brian, everybody, thank you so much.
You.
Thank you. Take care.